The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric with you. Hope everybody's having a great summer. Today we're going to do a podcast on ventilator management, and we're going to specifically look at ventilation failure or ventilatory failure regarding our COPD and our asthma patients and kind of how we deal with auto-PEEP issues and air trapping. I wanted to do this for a few reasons. The first reason is I've had an article brought to my attention by a few people. And the article actually was very intriguing. I read the article. I've read the article actually multiple times. I'm still kind of dissecting this. I've talked to a couple of my buddies around the country that are respiratory therapists to kind of get their view on it. And ironically, one had a positive view and the other one had a negative view. So very interesting. And I think in medicine, you have that. You have two different perspectives or multiple perspectives on a topic or concept. And that's the whole point of FOAMed, critical care education, is just to put the information out there and let you guys kind of decide. Obviously, I'll give you my opinion and kind of how I think about this. The second reason is if you're on Twitter, if you are a subscriber to our newsletter, you know that we recently sent out a newsletter announcing the release of our Ventilator Management, a Pre-Hospital Perspective book. This is something I've been working on for close to 2 years now. Very, very excited that I'm in the completion stage, in final editing. So the release date is going to be September 11th of 2015, so about a month away. And because of this, I'm going to do a pre-release sale where you can reserve your copy in advance for $29.95. It's a discounted price. The normal price is going to be $39.95. So not a huge difference, but we've gotten a lot of sales, or I should say copies reserved in just the first day. So I just want to thank everybody for that. I'm very, very excited. So I just thought it'd be fitting that we release a ventilator management podcast related to this, and that I just kind of make an announcement to all of our listeners. As I've said many, many times, we're nothing without you. I am blown away by the staggering numbers of podcast downloads with not only FlightBridgeED Podcast, but also Second Shift. I looked last night, and we're steadily increasing. We're up to 229% from last year increase. That's staggering. And, again, I owe it all to everybody, to the word of mouth, for people sharing this with your friends and colleagues, and for just being so kind and sending all the nice emails. This has been very, very rewarding, and I'm very humbled by this, so thank you. This podcast is specifically going to be looking at ventilatory failure patients and not so much the oxygenation side. I just want to kind of touch on patients that are in trouble as far as exaspiration and air trapping and auto-PEEP, and kind of hit on a few of these topics. So what is auto-PEEP? Right? And what is ventilatory failure? Well, we know that we teach two different kind of roads to taking care of our patients, and those are strategies that we look at. We have our injury approach, and our injury approach is all based on protecting that lung by using low lung protective strategies, low tidal volumes, higher rates, in an attempt to reduce acute lung injury and potentially ARDS. Right? We don't want to start an inflammatory response. We want to protect those sick baby lungs. Well, on the other side of that, we have obstructive lung strategy. And the obstructive lung strategy is based on COPD and asthma patients. These COPD and asthma patients are patients that are very, very difficult to deal with. And I've said it many times on other podcasts. When you look at dealing with a ventilator and transport ventilation, one of the hardest things that I think clinicians struggle with is maintaining an understanding of dealing with the ventilation aspect. Because we have to remember, we're dealing with patients, we're ventilating patients in a completely different way than we normally breathe, right? It's not physiologic. And so we have to deal with now an ID ratio. We have to deal with changes in how somebody exhales. And we also have to deal with actual underlying disease process if there's a specific shunt that's causing the CO2 regulation to be either hyperdynamic or lower than normal. So in our exasperated patients, like in COPD and asthma, we have a phenomenon where we start having airway narrowing, right? Bronchial constriction. These patients start becoming tachypnic, and oftentimes you know that they're actually more tachypnic than you and I. They're polycythemic. They have a higher red blood cell count. They have a higher hydrogen ion count, and they live at a higher CO2 range. So those are some things to kind of consider. They also live in a range of auto-PEEP that's much higher than you and I. And that's something I think we forget. We forget that patients actually live at a higher auto-PEEP range, and an auto-PEEP of, let's say, 10 for you and I may be high. That may cause us some difficulty. But for these patients in COPD and asthma, in the chronic sense, they may live at 10, at 12 centimeters of water. So we have to think that maybe an auto-PEEP of 12, 15, even though that seems extremely high, that might not be too high for them. So we shouldn't freak out about the whole auto-PEEP issue. So remember, auto-PEEP is something that is based on how well we get rid of our breath, right? We inhale and then we exhale. And we know that the inhalation process is very quick, and the exhalation process is actually double or triple the length. So we have to be cognizant of that. So these patients start having some type of exasperation, some type of triggering event. Their airways start narrowing. Because their airways start narrowing, they become tachypnea. They start having anxiety. They increase their respiratory rate. Well, if you think about an inspiration and an exhalation time, you only have so much time in that respiratory cycle. And if you're constantly inhaling, if that respiratory rate increases so much, every time you go to exhale or during the exhalation process, the patient takes another breath. So you're constantly starting to stack breaths. And that's where that air trapping starts occurring. Well, because that air trapping is occurring, it's keeping that air down into the alveoli. It's not escaping, and your alveoli become very, very engorged, and you have excessive pressures now that are being exerted against and inside the alveoli. Now, like I said, you have multiple types of auto-PEEP. You have something called a dynamic hyperinflation. This is the main cause of auto-PEEP in patients with COPD on mechanical ventilation, is closure of the airways, which limits expiratory flow. So the airways are closed off. They may have atelectasis trauma, and they just can't maintain expiratory flow. The next one is called dynamic hyperinflation without expiratory flow limitations. So this is auto-PEEP that can occur even if the airways are widely patent without intrinsic expiratory flow limitations. This may occur if the volume of the air delivered per minute is high. So if you have a really high minute ventilation, really high rate, and the exhalation time is too short to maintain that. So that's something that's obviously clinician-driven or clinician-caused. The last one is called exaggerated expiratory activity without dynamic hyperinflation. Although auto-PEEP and dynamic hyperinflation are usually thought to be synonymous, auto-PEEP does not necessarily imply dynamic hyperinflation. I think we always forget that. We think that there's hyperinflation that's causing that auto-PEEP issue. In this case, though, auto-PEEP may occur when strong expiratory muscle activity contribute to alveolar pressure, often the normal or even low lung volumes. So even though we're using lung protective strategy, this may cause an auto-PEEP issue. So again, a lot of times we can cause this issue by just the ventilator strategies that we're using. One of the things that I find when reading a study like this, and some of the things I saw when I talked to a few of these respiratory therapists, is that there are people out there that are looking at this article. This article was put out in 2005. All right, so it's pretty old, 10 years old. And, I know based on hearing intensivist and stuff, specifically Scott Weingard, MCRIT, he basically says that PEEP in a patient that's got a ventilatory failure is something you can argue back and forth. Some clinicians may say, yeah, let's turn the PEEP off, and some will say, 3 to 5 centimeters of water, basically matching intrinsic PEEP on a physiologic norm, is the right way to go. And he doesn't really push you either way. I think talking to these respiratory therapists that I've talked to, they feel like cutting off all the PEEP is a bad thing. You obviously don't want to go excessive PEEP as well. So I think we have to be very careful to look at an article like this, and I'll put this in the show notes, like I said. I really encourage you to read this. But we have a lot of strategies to deal with auto-PEEP and air trapping issues. And remember, the whole obstructive approach is based on lowering that respiratory rate down to 10 to 12 a minute, giving a physiologic tidal volume in the 6 to 8 mil per kilo range, lengthening the ID ratio out to 1 to 4, 1 to 5, giving pharmacology, and then waiting and seeing, right? Giving adequate sedation and pain management, placing these patients on SIMV, allowing them some pressure support of 10 centimeters of water, and watching them and giving them the correct pain management. Obviously, these patients become very, very fatigued, and that adds to this whole issue. But I think it's important to, if they have any spontaneous drive, to maintain them on SIMV. And again, I confirmed that with both of these respiratory therapists. Specifically, one of them was more in favor of SIMV than the other one. But again, you've heard my teachings on this. I really believe that SIMV is the best way to go. I've been taught this. I've been taught this by multiple RTs and intensivists from real high-level, level 1 facilities. And I know you may be working in a small facility. You may be working in an area that they still use assist control, and that's fine. I think in transport ventilation, SIMV is the way to go. So let me try to explain an analogy that I think this article uses that I think is pretty profound. And hopefully you can follow me. And again, I encourage you to read this. This is on page 807 of this article. When I put it in the show notes, it's going to be actually page 7. And so here it is. So the seeming paradox of why applying external PEEP does not make auto-PEEP worse has been explained by the analogy to a stream with a waterfall. In this analogy, the upstream part of the stream is like the distal airways. The downstream part of the stream is like the proximal airways. And the waterfall in between is like the site of critical airway closure. So think of the pressure in the airways like the hydrostatic pressure in the stream. Now suppose the tide comes in. Right? So suppose that the lower downstream side of the stream starts increasing in depth. That's essentially you adding external PEEP. So raising the height of the stream below the waterfall has no effect on either the flow or the pressure upstream of the waterfall unless the water level rises above the level of the waterfall. So you got to kind of picture this. You have an upstream side, you have a waterfall, and you have a low stream side. The low stream side is essentially your airway pressure. And if you add more airway pressure, like adding PEEP, that has to come up so far to actually cause a critical closure of that airway. So think of a Niagara Falls. How much volume would have to be placed in that lower pool to exceed the top of that waterfall? It would take quite a bit. So above this level, external PEEP increases the pressure upstream and exacerbates hyperinflation. So essentially what they're saying is that if you add too much PEEP, yes, you can definitely cause hyperinflation, and you can bring that lower stream above the waterfall and cause a critical airway closure. However, what they're recommending is if external PEEP is kept below 75% to 85% of the auto-PEEP level, worsening hyperinflation or circulatory depression is unlikely to occur. The reason why PEEP is beneficial to these patients is it essentially reduces the workload of breathing. And obviously these patients are very sick. They have very weak respiratory muscles, and that's why they become so fatigued and finally just kind of crap out. So adding PEEP to these patients reduces the workload of breathing, actually overcomes the opposing recoil pressure of the ventilator, and allows them to take a breath more unabated. So again, 75 to 80% of your auto-PEEP. So remember, on the LTV 1200, on the Revell ventilator specifically, you do an expiratory hold and you can identify that auto-PEEP. And so just maintain a PEEP level at least 75% below that. Now, I think a good rule of thumb on all patients, no matter what, a starting PEEP of 5 centimeters of water is a great point. And one of the things you can actually do on a patient like this is watch your high pressure alarm, right? So watch your PIP. If you apply PEEP of 5 and your PIP does not increase when you add that PEEP of 5, then you're not having any issues with hyperinflation. But if you add PEEP and you raise that PEEP up and you start seeing a corresponding increase in PIP, your peak inspiratory pressure, then that's where you need to kind of stop. That's where you're starting to get to that area where your airway pressure is starting to increase above the level of that waterfall, if that makes sense. So I think the rule here and the whole point I'm trying to convey is that we have to be careful to look at an article like this. We can do a lot of different things with our patients. Like I said, the obstructive approach is all about reducing that rate down, giving a normal physiologic tidal volume, extending the ID ratio out, giving proper pain management, proper sedation, place them on SIMV with pressure support, or, if you want to put them on assist control, then do that. But I think it's important to allow them to fire their muscles if they feel like they want to, right? We don't want to cause more anxiety. We don't want to cause any exasperation. My buddy Pete Gomez, he's a nurse and a RT, lives in Arizona, has flown for years, and we were just talking about this on the phone. And he specifically hit that right on the head. He will always put a patient on SIMV. Obviously, we're always going to watch them closely. We don't want them to overwork. And the big rule of thumb there, remember, is you never want somebody to take a pressure-supported trigger breath that's greater than 75% of your set volume. So an example of that would be if you had a tidal volume of 400 set on your ventilator based on ideal body weight. When a patient takes a spontaneously triggered breath in SIMV, you should never see them take a breath greater than 300 mils. If they're doing that, then that's where you need to dial down your pressure support and maybe give them some more pain management and sedation. So remember, pressure support in this setting is very, very sensitive. Always start at 10 centimeters of water, and for every 1 point increase or decrease in pressure support. So let's say I had a patient that was breathing at 400 mils, their set tidal volume was 400 mils, and they took a spontaneous breath at 400 mils. I had a pressure support of 10. On the next breath, what I would want to do, that's too much. That's greater than 75% of my set volume, right? That's 100%. So I want to titrate that down. So what I would do is I would decrease my pressure support by 1 centimeter of water. I'd go from 10 down to 9. And what that's equal to is approximately 75 to 150 mils for every centimeter of water you increase or decrease on pressure support. So very, very sensitive. This is something I've learned recently. I will never go up or down by 5 anymore. I'm only going to go up by 1 or down by 1 at a time because it is very significant. So I think the lesson here again is just utilize all your strategies. Don't use excessive PEEPs on these patients. Always check your auto-PEEP. Remember the whole analogy of the upper stream, the waterfall, and the lower stream. The lower stream is an indication of airway pressure, which is your external PEEP. And utilize the other strategies that we learn and we teach in the obstructive approach. Like I said in the book, The Ventilator Management of Pre-Hospital Perspective, I go into all this stuff in depth, conversational, written format, where I'm just sitting here talking to you just like this. So I really encourage you to check out the book. Real proud to see it out and released, and would love your review. We really encourage you to go on iTunes. If you haven't subscribed, we've seen a huge level of subscribership. We've hit 600,000 downloads now on the podcast, and we see thousands of downloads, but we only have a small fraction that actually subscribe. So we really would appreciate you subscribing. It really helps us out. Leave a review, helps us out as well, and we really appreciate your following and for everything that you guys do for us. If you're looking for a review class, we've got quite a few scheduled. We've got one coming up in Kentucky at the end of the week. It's not too late to register for that. We have another one in Toledo, Ohio at the end of the month. We have another one after that in Toledo, Ohio at the end of September. And then we also have one in Powell, Wyoming, the middle of September. So just go on the website, www.FlightBridgeED.com, go to courses and check out the locations that we have. Don't forget to reserve your copy of the book. And we thank you so much, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.